Yes, we can. Do you mind also
Okay.
turning on your video just so we can see you?
I'll do that and then I'll put off just so that it doesn't interfere with the stability. Where is that video thing? Start video,
Okay. If
right?
it will interfere with stability, then that's okay. My suggestion was to have it on for the entire period, but if it does interfere, then it's okay to keep it off.
Yeah, I'm actually a real person. Yeah, so I'll see at the end. Yeah, so thanks so much for the invitation. I know I have been asked and I kept on promising, so I'm so sorry about that. I'm going to talk about secondary distribution of HIV self-test to promote male partner and couple testing in Western Kenya. And Harsha Tirumuthi is my permanent PI for all the studies that we've done. And so we do know that globally about 20% of HIV infections remain undiagnosed per the UNAIDS of 2020, and testing men and testing in men and couples and key populations remain low generally. In Kenya, according to the KenFIA 2018, 27% of HIV positive men are unaware of their status compared to 17% of women. And so we need innovative strategies to increase testing coverage, and HIV self-testing is one of such strategies. Many studies have been done that has shown that it's highly acceptable, and right now it's been included not just in the national testing policy in Kenya, but also in other parts of Africa and other parts of the world. So we know that the conventional testing has multiple barriers that make most people don't go for testing, but specifically men, issues around structural barriers and health systems specifically, lack of privacy, stigma associated with testing. Incidentally, stigma is still high, especially in certain regions where we haven't had a lot of programs on HIV. There's inconvenience of time and location, and for men, characteristically, they're low users of health facilities where testing would be. Issues around cost, not just cost of the test itself, which mainly is not much. Sometimes it's zero, but the cost of actually going in terms of and so on. And some still do proxy testing through their female partners. The lowest testing percentage are mostly men, as I've said, young people, generally key populations, except in areas where there's a KP program funded by PEPFAR, that's pretty well tested, and then other vulnerable and populations, including key and priority populations. And so moving testing, one of the ways that have been used to reach hard-to-reach populations or to test hard-to-reach populations has been to move services closer to them in the communities. But we do know that if you take services, especially like the home-based testing, you know that mostly you find the women, you find the children, you rarely find the men. And so we still get the gender gap remaining even with home-based testing, even with the callbacks. Demand creation with incentives have also been tried, but this has limited scale-up ability, and especially skepticism around sustainability, because if you give incentive, are you going to give it forever? And therefore, the different ministries of health may not take it up. We've had the PNS, the partner, assisted partner notification services, but acceptability has been limited. And therefore, we need to look at different other models of distribution of testing overall, but especially HIV self-testing, so that we can reach the low testers wherever they are. Distribution for HIV self-tests are mainly in two categories. One is the primary distribution, and then there's the secondary distribution, where the primary distribution is where an index person is given the test or picks it up from a pharmacy, a dispensing machine, a clinic, a community outreach contact person for purposes of self-testing to test themselves. While secondary distribution is where the index person is given HIV self-test to give to somebody else to test. And so what I'm going to talk about is the second type. And so I will run us through 4 studies that we've done. We've done more than 4 studies. I saw Marie Downer, we've done one with her. but that was in secondary distribution. So I look at the 4 studies and how they have built on each other to where we are, and how the results are, whether they're consistent or not consistent. So one of the studies was to look at acceptability, feasibility, and safety. And that was really, really early on in 2012, 2013, when HIV self-testing was just gaining momentum in terms of studies being done. And we were looking at whether it's acceptable, feasible, and safe to promote partner and couples testing in sexual and social networks. At that point, we were giving self-tests, and then you could give either your friend, your family, but also your sexual network. And then the second one that moved from there, and I'm going to explain in the next couple of slides, is looking now at the impact. The first one, we were not looking at the impact. We were just looking at whether it's acceptable, safe, and feasible. But the second one, we were looking at impact of secondary distribution of self-tests by pregnant and postpartum women on both male and couple testing. We do know that that's a challenge in most of our facilities, where women come on their own, and multiple strategies have been put in place to attract men to come to the facilities for testing together with their partners. And then we moved on also to look at do a cluster randomized trial with high-risk women to promote partner testing. And then finally, end of last year, actually a couple of months ago, we were trying to see whether this model can it work with adolescent girls. And we were not even talking about adolescent girls and young women, we were just talking about adolescent girls themselves, ages 15 to 19. And so for the first one, where we were looking at feasibility, acceptability, and safety, and that wasn't an impact study, we enrolled women in antenatal care, postpartum care, and female sex workers. And we wanted to determine whether providing multiple self-test women can promote partner and couples testing. And therefore, what we did was to give 5 kits to female sex workers and 3 kits to ANC and PPC women, with a goal of identifying how partners take the self-test. Do they take it individually, or do they take it as a couple? And then to assess if those who test, do they go for confirmatory testing? And those who are positive, do they link to care? And of course, we looked at also just the safety, because there's always the concern that if the test kits are given to the women and they present to their male partners, the male partners may become violent. And so we were keen on intimate partner violence. And so we enrolled and infected women at 2 sites in Kisumu, drop-in center, which is for female sex workers. And then we also went to one clinic, that the NCH clinic, where we enrolled the antenatal women coming for antenatal services, and also postpartum. These were women aged 18 to 39 for ANC and PPC, and 18 plus for sex workers, had to be resident in Kisumu, and had to have at least 1 sexual partner, because you had to have a partner for you to be able to distribute to them. And for the pregnant women, had to be less than 20 weeks gestation. And for the postpartum women, at least more than 1 or more sexual partners, and had to be more than 6 weeks and less than 12 months postpartum. And then those who believe that violence would not result from discussing sex with their partners, because this was just exploratory and we didn't want to cause more harm by the intervention. And so at enrollment, participants were assessed for eligibility, consented, and then use of HIV self-testing was demonstrated. And we asked the participants to demonstrate back, because that confirmed to us that they're able to demonstrate to their partners when they go home. They were issued with test kits, 3, as I said, for ANC, PPC, and 5 for female sex workers, and they were given 3-month appointment. We gave them a 3-month window within which they would test. And then women were then contacted by phone month 1 and 2 to assess whether they had distributed and whether there was any issue around partner violence and so on, just checking on them, so to speak. And participants were also asked to call the clinic immediately the partners tested. And when they did that, we did a follow-up interview to assess whether the partner tested alone. And if they did test alone, did they share the results with their female partners? Or if they tested as a couple, in which case the partner saw the test result. And we also asked whether the status of the partner and whether they went for confirmatory testing and linked to care. We also wanted to find out the sexual behavior and decision-making. The key thing about sexual behavior and decision-making is the assumption that if you have test kits and you give your partner and you test together as a couple and both of you test positive, there are certain decisions that you're going to make about having sex going forward, that will it be protected or not. And if you test discordant and if you test concordantly negative. So it's like, what are those decisions that partners make when they test together? And we call it point of sex decision-making, just like point of care. And then at 3 months, participants were followed up and interviewed in person. And so we enrolled 327 with 327 with 280 enrolled, and some were ineligible. And so of the 280 enrolled, almost all of them completed one or more follow-up interviews, and then some, just 4% was lost to follow-up, and one withdrew from the study after completing the first follow-up interview. So the person is also counted under the 265. And so what did we find? Of the 280 that were enrolled, a total of 901 self-tests were reported to have been used by either the participant. They were allowed to use it themselves if they wanted, or distributed to others. And so about 709 were distributed to others, and 192 the participants used themselves. And of the ones that were distributed, 97% were used, or reported used, I would say. And then about 20% were offered and were declined. And so the 97 is of the ones that were offered and accepted. But there's about 20% that were offered and declined. And then there's 15% that were actually distributed, but the partners never used. And so when you look at the graph on your, it's on my right, for the when you look at the first is partner reported distributing. So they distributed really well, 91 for antenatal, 86 for postpartum, and a little lower, but still 3/4 for female sex workers. And then reporting being present during testing is almost everybody was present, like perfect match for antenatal and perfect match for female sex workers, but postpartum care, just a few were not present during testing or was not shown the results. And then couple testing is a little lower, was 47% among antenatal women, 58% postnatal, and 62% female sex workers. And so this is just general, the positivity. We identified about 5% in ANC, 3% in PPC, and 15% in female sex workers that whose partners were positive. This is positivity of the male partner. And then of those that were positive, how many sought confirmatory testing? And it's not much, although the figures are very small for ANC and PPC, but 63% sought confirmatory testing. And then those who, after seeking confirmatory testing, and the 60% were actually linked to care. So low, but still better than if they didn't even know their results in the first place. And so I talked about point of sex decision making. We actually did a sub-analysis to look at in transactional sex encounters, whether HIV self-testing was potentially useful for decision making when there are incentives favoring condomless sex. For example, I've tested with you and you're positive and I'm negative, and then I want to use a condom, but you offer me more money. And then, so how many were accepting more money when they knew their partners were positive? Just because condomless sex was more lucrative and could have still resulted in greater risk taking. And so when you look at the chart on your left, what you see is a difference of, overall is a difference of $11.7, about $1,200, in terms of if this condomless, the yellow, and the green is when a condom is used, so the charges. And this is somebody that you're having sex with after you know their HIV status. And then again, when you look at those with low education, it's low, about 1,000 shillings. And those with higher education is high, about 1,500 Kenya shillings. That's the difference, overall, the difference between condomless sex and sex with a condom. Okay, so a quick one is that the other thing that we found in terms of sexual decision making is that sexual intercourse was less likely, and condom use more likely when the partner tested positive if they tested as a couple and the woman knows that the partner is positive. And what we found is that 62% with negative partners compared to 18% with positive partners had sex. So the others, I think, took a break from sex, maybe to think about what to do next. And then 44% with negative results versus 100% with positive results use condom. So again, condom use was like universal among those whose partners tested positive. So that brings us to the end of the first study. And remember, we said we worked with antenatal women, postpartum women, as well as female sex workers. So when we move to the next level, we split the population into two. We only now first took the antenatal women and postpartum women, and we wanted to look at the impact now. And so we enrolled women, again, age 18 to 39, and the eligibility is the same as in our feasibility study. And here we now had, it was a randomized control trial where we had the HIV self-testing arm and the control arm, where the HIV self-testing arm, women were given 2 oral fluid tests and shown how to correctly use, and then given written and pictorial instructions on guiding them on how to use, while those in the control were given a referral coupon on the right, and the referral coupon, this is the front, and then the back had directing them to where they can get confirmatory testing in the 3 languages, English, Kiswahili, and Luo. And so the quick results is that a total of 1929 women were screened for participation at the 3 study facilities. This number is not correct. We didn't screen so many. Yeah. A total of that was screened. Yeah. I was thinking it's the next study. But unfortunately, only 32% were determined to be eligible. And these are the reasons for ineligibility. No primary partner positive already, non-positive, intention to leave the study area outside the age range, and fear of violence if they were to go home with either referral coupon or HIV self-test. And then a whole 37% declined to participate. Many of them said, because they were coming to the facility, they do go through their normal services, and then we would ask them to participate in the study. And a lot of them, said, I'm running home, I have to cook for my kids, and that kind of thing. And so we ended up enrolling 600 and randomizing 600. And we completed follow-up for 95% of the 600 and 94% in the HIV self-testing group, and 95% in the HIV self-testing group and 94% in the control group. So the results in a nutshell is that there was like really significant difference between couple testing and partner testing between the intervention and the control group, such that for male partner testing, almost 91% in the intervention group reported tested, compared to about 52%, with a 39% difference. So the couple testing was also high, slightly lower than individual testing, but still much higher in the intervention group, self-testing group, where 75% of the men reported testing compared to 33%, again, giving us a 42% difference. When you look at, I don't know why this thing can't disappear. The results in terms of, we looked at these results every which way in terms of trying to control for this, trying to control for that or the other. And even those that reported intimate partner violence at the beginning, the effect was still the same in terms of this reported in the intervention and the control, and it's about 50%, actually even higher, a bigger difference, but still significant in terms of the difference between those who tested in the intervention and those who tested in the control. And then we also looked at, those whose partners tested, had not tested recently, because we wanted to see whether that had any influence of those who are going to take up testing. And we did not see any difference in terms of the difference between intervention and control was sustained, even with those who tested at least one time, those who did not test at all, and those who did not even know whether their partners had tested. Again, what you see is really a significant difference between intervention and the control. So that brings us to, remember we said we had three populations in the feasibility study, ANC and PNC women, as well as female sex workers. So we separated them. And then we did a study that was now just looking at not necessarily female sex workers, but women at high risk of HIV infection that included female sex workers as well as others who sell sex. This was now a cluster randomized trial with eligibility of 18 years and above, negative, and we did on-site testing, more than 2 partners, equal to or more than 2 partners in the last 1 month. And we did GIS mapping to identify where the facilities were, to identify the beaches and the hotspots. Oops, sorry. The beaches and the hotspots, and that's the picture on the left, on the right. And then we pair matched them. We identified 66 clusters, and we pair matched them so that beach communities were with beach communities and hotspots with hotspots. And then we randomized each in the pair to intervention and control. And then once we did that, we did household listing to identify those who are potentially eligible, and enrolled about 30 women in each cluster. And the 30 women were randomly selected from the household listing. So for this, it was interesting that we gave 5 HIV self-tests, but then they were free to come back for additional testing, because these are women who are selling sex, and therefore they have partners coming in and going. And therefore they could call us, or they could come for replenishment. And we also gave them the instructions as we did for the others. And we also encouraged them. For this one, the interesting thing is we did not just give anybody, but we told them that they need to be very selective in who to provide the self-test to, and that is only those that they were going to have unprotected sex. And not the ones that use condoms, they didn't have to do that. And control, of course, we had our referral coupon. Oops, this thing has a life of its own. Where we gave them 10 at the beginning, but also asked them they could come back for more if they wanted. And the referral card was designed to encourage women and their partners to seek tests, and saying knowing your HIV status is an important step in staying healthy. We encourage you to visit your nearest VCT site. We use the word VCT because that's what's known in the community, rather than HTS. VCT site for HIV testing and counseling, or call that for more information. So that's the one, the coupon that we gave them. And so the outcome was HIV testing, and we conducted testing at 6-month interval up to 24 months, but with an average of about 18, actually about 19 months, with a primary outcome of HIV incidence and secondary outcomes of both couple and male partner testing. But we were also keen on identification of HIV positive partners who had not known that they were positive before, and look at the sexual behavior and safety. You don't need to look at this whole thing, but just that we enrolled 2,090, and the mean follow-up was 19 months, and we had more than 85% retention, which was really good because it was in the entire county and there was a lot of crisscrossing. So in terms of results, when you look at the number of sexual partners in the past month, this is true because that was an eligibility criteria. And then when you go to this other side, number of transactional sex partners, 1, 2, and 3, just in terms of the background characteristics. So over 80% reported regularly exchanging sex for money or material goods, and only 36% reported condom use at the last sex, which is really low for a sex worker. Looking at self-test and referral coupons in terms of those who received and actually used, then what we see is that at month 6, the sexual partners, the majority were given the same, more or less the same. The control gave the referral coupon, intervention gave the up to about four self-test kits. And then the next is where the partners use themselves, either to test themselves on their own, although they had been tested at the facility, or to test together as a partner. So we counted that as partner testing themselves. And so what you see is that the testing actually went down. One reason could be that the partners that they tested at the beginning had already been tested. So if you're going to have repeat sex with them, then it was not necessary to test them again. And so what you see is kind of a drop off all the way to month 24. Effects on primary partner and couple testing, again, what we found is the same, that intervention is much higher for testing of a primary partner at all the months, month 6, 12, 18, and 24, and then control lower all the way, but more consistently lower, while intervention is consistently higher. Then looking at couple testing, again, the same story at month 6, 12, 18, and 24, intervention was consistently higher and control consistently lower. And so how many HIV positive sexual partners did we identify in the course of the study? And so in the intervention, the self-test was able to identify 25.7 men who previously didn't know they were positive, and this compared to 13.4 using referral coupon in a health facility with an incidence ratio of 1.87 and confidence interval that shows it's significant. And then once you adjust for all this, then it's actually even improved somewhat. And so finally for this, having sex with any partner who has tested positive or refused to accept the HIV self-testing, how that sexual decision-making behavior following self-test. And what we see is intervention decline, those who decline to have sex with partners who tested positive or refused to accept HIV self-testing or referral card. What you see is that for self-testing is high in the month of 6, and then it's the same in months 12, 18, and 24. And you also see the same for those who used condom with any partner post-testing. I mean, for those who used condom post-testing and tested positive or refused to test, to accept the test kit. At month 6, significantly higher in the intervention, and then slightly higher at month 12, and then very little difference. And actually at month 24, those in the intervention were actually less used condom. And one of the explorations that we've done, and we submitted a paper for qualitative, is to find out whether they felt like they were now protected and therefore there was no need to use a condom, whether HIV self-testing actually did have a negative effect towards the end of the study. So we explored that. And then finally, I don't know how I'm doing with time.
You're okay with time, you're okay.
Okay, so finally we have among young girls, we wanted to see, always, most of us who do research, you always say 18 and above, because you don't want to deal with parental consent, caregiver consent, and so on and so forth. But I think it is also important to test out, innovative strategies on young people so that they can also benefit as much as the adults do. And so we wanted to determine whether adolescent girls can safely offer, given their age, and sometimes they are in age disparate relationship, to assess whether oral self-testing improved testing among their partners, to document adverse events. And we also qualitatively explored their experiences, how easy or difficult was it, and so on. And that's not part of this presentation. We enrolled adolescent girls age 15 to 19. Although the qualitative view focused on only 15 to 17 because we thought they were much younger, and we just wanted to see how easy or difficult was it to introduce testing to their partners. Had to be HIV tested, negative. We tested them on site, and the partner must have tested more than 6 months ago or is of unknown status. And also that they were planning to meet their partners in the next 3 months so that they are provided with an opportunity to offer the self-test kit. Because we didn't want those that you are in school or your partner is wherever and you're not going to meet them, so you won't have an opportunity. And so that was an eligibility criteria. It was a randomized trial. We gave 2 test kits, and again demonstrated by staff and back demonstrated by participants. And then we gave 2 referral coupons and they were asked to call if their partner tested, which then prompted a phone-based survey or in-person survey if that's what they chose, because a number of them were using phones of their parents or their caregivers. And then at 3 months, those who were not called to report partner testing were contacted for end-line survey. And so in years, the majority, and this was intentional. We wanted to get a lot more of younger adolescents rather than old adolescents, 18 and 19. And so 72% in the intervention, about 70%. So overall 71% were age 15 to 17. 70% had completed at least some level of secondary and above. And only 10% were married, and 74% did have kids. And primary occupation, the majority, actually 2/3 of them were students, and average monthly income was just less than 1,000 Kenya shillings. So in terms of sexual behavioral characteristics, age at first sex, there's 50% actually had sex, about 50% by age 14 and 15. But remember, a requirement or an eligibility was that they must have been sexually active and have a current partner. And so it's not the same as general community. And then about 40% had sex at 16 and 17. Age of partner, we asked whether they're the same age, less than 5 years difference, more than 5 years difference, but the majority were not the same age, but less than 5 years age difference, but 42% also were more or less the same age. So these kids are having sex with their age mates quite a bit, and those were slightly older, rather than, unless they were not reporting correctly, rather than people who are much older as is always believed. Number of sexual partners ever, one for the most of them. Regular partner ever tested for HIV, 1/3, yes and no, but also a slightly larger majority don't even know whether their partners are tested, and then condom and last sex. They reported pretty high, and I think, as we all know, getting pregnant for adolescent girls is more serious than getting HIV, and that's why we want to believe that condom use was higher. And so, was there intimate partner violence in terms of results? Yeah, at baseline, there was only 3 and 1 that reported intimate partner violence in the previous 3 months. And at follow-up, 3 months follow-up, it's also 1 and 2. So really, there's no difference. It's just 5 in the intervention and 4 in the control. Were they able to discuss HIV testing with their partners, whether they were in control or intervention? And really, all of them did. And by the way, I just want to mention that we had done a previous study just to ask them whether that was possible before we even started the randomized control trial, to be able to ensure that we don't put them at higher risk. What was the partner reaction to testing? They were very positive, reported by the majority. And how easy or difficult was it for them to actually demonstrate testing? And we find that the majority didn't have a problem explaining and demonstrating. And so the final result is, in terms of intention to treat for partners who tested for HIV, what we have is 95% tested in the intervention and close to 74% in the control, with an odds ratio of 5.4. And partner tested for HIV as treated now is slightly higher here. It's higher on both sides as expected, and with a higher odds ratio. Couple testing, 83 and 60. What you see here, and of course partner violence is low, 5 only. What you see here is like actually among these younger people, those in the control did even better than the adults in the previous studies that we had looked at. And so in conclusion, from the pilot study, we gathered that secondary distribution of HIV self-test was feasible, acceptable, and safe in promoting male partner and couples testing. And then among female sex workers, about 16% of HIV positive partners were identified. 63 went to the health facility for confirmatory testing, and 60 were linked to care, which is a plus. A lot of times people think that this is low, but think of what would be there if they did not test. They would still be in the community with unknown HIV status. And then in the Jipime study, we also found that it's safe and effective in promoting partner and male partner and couples testing. And the results suggest that this is a promising way to ensure that self-tests reach people who currently have low rates of testing. In the Jikinge study, which is now the cluster-randomized trial, It increased awareness of female sex workers, sexual partners' HIV status. So they did get to know their HIV status, but as we reported, condom use actually went down at month 24. And so we are concerned that maybe they had this false sense of security or safety. There were unsustained changes in withholding sex. So withholding sex was just, and condom use was just there at month 6, and then it was not sustained over the 12 months, and we did not see any effect on HIV incidence. And the incidence was extremely, extremely low. So finally, for the last one, we called it Wasichana Wetu. Adolescent girls find it easy to distribute HIV self-test to their partners, and the partners are generally receptive from what they reported. And we also found that the HIV self-testing is both safe and effective in this very young population. So overall, our secondary distribution model can facilitate reaching the remaining 27% of Kenyan men with undiagnosed HIV, although we do need additional HIV prevention interventions. And we also have demonstrated across the board that it is acceptable, that it is effective, and that it is safe in a range of populations. And therefore, the approach warrants programmatic consideration as countries and counties roll out self-testing and developing self-testing policies. So I want to acknowledge this whole group that were part of one study or the other, and the funding from NIH, and the last 3 are the funders for the 4 studies. Thank you. Over to you.
Thank you. Thank you so much, Dr. Kawango. You literally took us through 3 studies. I thought we were going to do 1, but this is amazing, amazing, amazing. So I think we can go straight into the Q&A section. I have seen about 2 or 3 questions in the chat, but perhaps before we get to that, and just to open this part of the session up, just a comment from me. I think it's good to hear that condom use was more likely when a partner tested positive. I also had a question at some point regarding intimate partner violence cases reported, but I think you've talked about that. However, you only mentioned that in the 3rd study. So I was curious whether there were any reported cases of intimate partner violence in the other 2 studies.
Okay. Do I go ahead and respond?
Yes, please go ahead.
Yeah, I got your second. I don't know what the first question was. The IPV one is the one I got.
Yeah, so that's the question. The other one was just a comment.
Oh, okay. Yeah, so the first study, actually, we had, I think there was 6 altogether, and one was pretty serious. One was pretty serious where a female sex worker offered HIV self-testing to a partner, and then 1 month after that was done, the partner tracked her down with a machete, and she had to really run, get into a motorcycle and disappear, and they followed her. And so what we did at that point, part of the things that we were doing was to collect information on how to make it safer as part of the interview, part of the questionnaire. How do we make it safer for women who are sex workers, for women in ANC? And then we used those messages to prepare counseling messages for subsequent studies, so that we would know how do they approach their partners, what do they need to do, what should they not do. And so that is how then we trained the next group, where we then just got 5 IPV, and all of them were minor. One of them, the second study, the Jipime, did not have any IPV. And then for the girls, I think there was 1. And the reason being that as we were moving, we started from the first one when we had those serious ones, then we were developing and refining counseling messages that then or educational messages that we would give before we distribute the self-test kit, so that they know how to prepare and how to give and when to not give.
Okay, thank you for that. Thank you for that response. Pauline Fiona, your hand has been raised for quite a while. Talking permitted, did you have a question? Okay, perhaps we'll come back to Pauline in a short while. Let me just take the questions in the chat box. So Javel Okach said that a point of concern, which age group faces a lot of challenges in knowing their HIV status? Because according to your statement, it is just couples and men.
Which age group?
Faces a lot of challenges in knowing their HIV status.
Okay.
Yeah, and he says, he's asking that because according to your statements, it's just couples and men.
But men also have age. Okay, yeah, that's fine. I would say those who have, actually for men, it's across the board. Because young people, by virtue of the fact that they're young, because young people overall, whether they're men or women, I mean, they're girls or boys, men or women, young men or young women, have a lower testing rate compared to older men or women, older in the sense that they are above 20 and above. And then when you look at the men in the reproductive age, which is usually 15, but I like to say 20 to about 49, they also have a problem. And a lot of it is not because they fear. There's the fear of testing, yes. There's the fear of just the finger prick. That's why HIV self-testing is more acceptable. But there's also just the fact that they don't have the time, to be honest. From what we've heard, they just don't have the time, given the engagements, and they're also not quite free to go to a health facility, a general health facility for testing. And then the older ones, the much older ones, 50 and above, feel like they're not at very high risk, you know? And so it's different dynamics in different age groups for men. But of course, we also have others, young people themselves. I talked about key populations. I talked about, which is the other group I talked about. I talked about other groups that are also testing at a lower rate compared to the general population.
Great. Javel Okach, I hope you got that response. We have a question from Stephen Mwakoma, and he asks, what incentives do you use to ensure that the key populations cooperate in the research for it to be successful? I think this points towards something you had mentioned. One of the strategies that I use is to incentivize. So I think he's just curious about that. What incentives are usually used for such studies?
What we have is just a normal compensation for time. We just make it slightly higher. We usually give generally 300 shillings to 500 shillings, but for sex workers, that the high risk women, we give 500 shillings, and then we also give transport. And that is just compensating for their time. That's really not, not an incentive, so to speak. It's for the lost time. But what in other studies, not this one that we've done, when you explore, is that sex workers also sometimes want a break. And when you are offering them 500 shillings, and probably when they come, they used 100, and they're telling you they used 300, so they've gone home with 700 shillings. They can actually choose to take a break from sex work so that they are getting 700 shillings without having to sell sex to be able to get that. So that is the incentive that's not like intended by the study. The study just gives that, and that's approved by the IRBs. But to them, you are able to get money without having to have sex with someone. It is in and of itself an incentive.
Great, thank you for that response. Lee Omondi asks, are there any cases that tested negative from the self-test kit, but tested positive when they went for the confirmatory test at the facility, and whether this is possible?
It is possible, but it didn't happen. What we had was, I think, 1 or 2 positives that then tested negative. And so we thought they were probably at the window period. And we advised them so that they wait and then they go for testing when antibodies could show. But we've not found where somebody is negative and then they test positive. The HIV self-testing is a screening test, and therefore it's very sensitive. And picks whatever it is, yeah. So you expect more false positives rather than false negatives.
Great, thank you for that. I don't see any other questions, but I was wondering if you could perhaps talk a bit about, you mentioned that there's another qualitative study that you undertook. So would you talk about the part of that explains why condom use was lower, especially towards month 24? I think that would be a point of interest for a lot of us in this call. So perhaps just a bit of insights.
Yeah, when we did actually should be out in the next month or so, when we did ask them, and when we were asking them, we did not know what the results would show because we were carrying out these studies concurrently. We had it at baseline and then I think 12 months and then around 18 months. And so we did not know what the results would show. But then it kind of really fitted well with the narratives that they were giving that, you know, if you test with your partner and you know their status, you're more prepared and therefore you negotiate. At the beginning, even the positive will shock you, but then later it's like you now talk together. And then at the very end, there was a sense of safety that the women said, at least in the qualitative, there's a sense of feeling like, I now know my status, I know the status of my partner, and therefore I don't need to use a condom. And that was more frequent at month 24, among those who were in the intervention, which is kind of a worrying trend in terms of we wouldn't expect an intervention to actually reduce the other effective interventions as well. And so that's one area that I think as we are rolling out this secondary distribution, good as it may be, we need to just pay attention to that. And I think probably we never noticed it in the earlier studies because we terminated the studies much earlier. This was a much longer follow-up. The others were 3 months and 6 months. So probably that's the reason why we were able to observe something that we never observed in the previous studies.
Great, thank you.
A false sense of security that came out in the qualitative very clearly.
Thank you for that. Yeah. And we do look forward to the results of that as we begin to roll out those results. Looking forward to reading more through that. I don't see any other questions in the chat. Anyone with a question, you could raise your hand. You could speak directly to Dr. Kawango. Before we close this out, I would not want to close out any questions or any points of concern. Okay, so Dr. Kawango, I don't see any raised hands and I don't see any additional questions. I think your presentation was quite simple to follow, quite clear. So thank you very much for joining in to share a lot about 3 different studies that you have conducted. With that, I would like to bring this to a close. We had set this up for an hour and I think we are right on the mark. The aim of these webinars is usually to connect people such as Dr. Kawango who are actively generating new knowledge for the HIV response, and we connect to people who are in programs, people who are in policy, and the general public so that we can all learn from the work that she is doing. We have also been live streaming on Facebook, so a few people who did not join the call on Zoom were joining via Facebook, and we appreciate everyone who managed to take time out of our busy schedules to join in this webinar. We look forward to having you in the next one. With that, thank you very much, everyone. Thank you very much, Dr. Kawango. I would love to.
And thank you, everyone. Thank you so much for the invitation and for everybody who attended. And hi, Carol Ngare. I've not seen you in 20 years. Okay, I'm done. Thanks.
Great, thank you. Thank you very much. Questions on whether the slides can be shared?
Yeah, we already shared with, I'm not sure who it was, but somebody from your team.
Yes.
Yeah, we shared with somebody from your team already.
Okay, great. So I'll be able to share those with the people who are interested. I will get their email addresses from the chat box. Thank you. Thank you very much, everyone. Closing this out until the next one. Goodbye.
Goodbye. Thanks, everyone. Take care.